And it gives me a great pleasure to introduce my co-chair, Dr. Michael Saag, who everybody's familiar with, so we won't give a big introduction, but he's going to lead us into our ART-based case discussions.
Great. So I'll have the panelists come up, and those of you who have been to this meeting before, this is a kind of free-form case discussion that really is sparked every year by questions that I get or that I hear from other providers that come up, and to orient you, each case will be preceded by a question so that you're not struggling to figure out what's the point of the case, and that orients you, and then it makes things go a lot smoother. The first part I'm going to go through a little bit quicker because there's some meaty stuff towards the end I want to make sure we get to before we run out of time. And I think we've covered a lot of these before, so almost some of the beginning is more sort of whatever group think, just to see where we are as a group, focus group kind of thing, and then we'll move on. So our panelists, Dr. Lennox, Dr. Springer, you know Dr. Carlos Del Rio. Those of you, especially from the Atlanta area, know very well. He's been at Emory for quite a while, just recently been appointed as the chair of medicine, and that's really great news for everyone except Carlos. And Dr. Melanie Thompson, who has been in practice here really since the beginning of the HIV epidemic or close to it, and is a great primary care provider, but also an expert HIV provider. And then Dr. Steve Grinspoon, who we've already alluded to, and he's going to speak to us this afternoon about the REPRIEVE study in lipid disorders. So we have, and he's at Harvard Medical School and Massachusetts General. He's head of endocrinology. So let's move forward. Not sure why it's not advancing. Oh, yes. This is a clicker use disorder that this one works, so we don't have it anymore. We gave a little buprenorphine, and we're all better. So we're going to cover a lot of topics: initial therapy, when a regimen fails, issues in pregnancy and breastfeeding. Trouble adhering, patients who are trouble adhering to oral regimens, management of hepatitis B, we'll get to that question we heard earlier, dealing with weight gain, and then STIs. And Dr. Kim Workowski hopefully will be joining us. She's got a meeting with the dean at Emory. I guess that's about being called to the principal's office. You usually don't turn that down. Okay, so here we go. The first question is, what regimen should I use as initial therapy if a 48-year-old guy presents newly diagnosed, he's asymptomatic, the viral load, you get this back. A lot of times we start therapy without it, but in this case we have it. 280,000, CD4 count 65, other labs are normal, wild type virus, no prior medical history, normal renal function, he's okay to start therapy. So which of these regimens might you choose? Pick your favorite. This is the focus group kind of stuff. And we'll go ahead and see what we say. Yeah, we're going to be on the Beatles all, those of you. It's a thorn in the side of Dr. Duac, who hates the Beatles mostly because his parents liked them, which I found an odd reason. Let's see how we feel when all right. So 85%. Dr. Del Rio, I'll let you kick it off as the chair of medicine.
I mean, I think I'm with the 82% or whatever percentages. This is, a lot of those regimens are all pretty good regimens, but this fixed dose combination is something that is easy for the patient to take, and it's hard to beat that, right? You could potentially say, well, how about dolutegravir 3TC as fixed dose without additional drug, but I remind you, this patient's viral load is above what the viral load was that you would consider safe, of over 100,000 copies. If he had 60,000 copies, maybe that's a good idea. But again, you didn't tell us anything about hepatitis B status also in the individual, and that's something that I would like to see as well. In order to do that, you can go with the with TXF, XTC, fix dose combination plus dolutegravir, that also works. But again, now you're talking about 2 pills instead of 1. As somebody who takes medications, I find it confusing once you have to take 2 instead of 1. So you want to make something easy. And I've learned from you that the best regimen is the easiest to take and the one the patient is going to tolerate and take. So I would start with the TDF, FTC, bictegravir. And if whatever happens or the person doesn't do well, then I would ask myself why, and I would see what we need to do. Again, the person may not want to take pills, in which case the, cabotegravir rilpivirine option is a possibility. But it's not something I would start the person on.
Right. So, Melanie, you want to add to that? What about option C, that 8%? Would you start right away on dolutegravir 3TC here with the viral load of was 280 and the CD4 count was 65?
So I go with Carlos on that. Makes me nervous to start patients with a higher viral load in this combination. But I also just want to comment on the cabotegravir rilpivirine. I think, I'm sure we'll talk later about starting that regimen in people with viremia. But I think not in this case, not until the virus is suppressed. And, this is somebody who has a lot of options ahead of them. But you would really want to get this patient suppressed and then see if that is an appropriate regimen for them down the line. And then I would just remark on the boosted darunavir regimen that, the reason that is not first line anymore for guidelines really has to do with the boost. And that there's so many drug interactions and so on, plus some side effects that, unless someone has, you're suspecting that they have integrase resistance, and I'm sure we'll get into that, I wouldn't go there.
So one thing I would add, Mike, I think today in 2024, when we see a person like this, when we see a new patient, besides doing all the screening that we're asked to do, I would really want to ask this person, I put my public health hat and say, why did this person get infected and why did this person not access PrEP? I would love to know. I think every new infection today in this country where we have, PrEP, it should be considered a public health failure. Something happened that this individual got infected, and I think we need to use that to inform the system, because why did this individual need therapy when he could have prevented it? And we have to know.
That's true. In this case, he probably was infected years ago, but your point, I think, is well taken, especially from public health. Steve, real quick.
Just another perspective is, I'm a metabolism person and leading Reprieve, and I can't go into huge detail on this because it's not published, but we have had the opportunity to look at, everyone was on ART in Reprieve, so we've had the opportunity to look at ART with respect to cardiovascular disease. And I can say that there's not a huge differences between regimens, but the one thing that really does contribute is having a detectable viral load. Yeah. So the important point being, chronically long-term, you need to have people on effective therapy, and that will actually reduce cardiovascular disease.
Absolutely. So we're going to go back to the future here and ask, in 2 years from now, picking up on Dr. Duak's talk, same story, so you don't have to review the history, but now you have options like lenacapavir, doravirine, islatravir, lenacapavir, which Dr. Lennox talked about, broadly neutralizing antibodies. This is a hypothetical implantable device where I just threw out lenacapavir plus islatravir. That doesn't exist right now, and it may not be developed, but just the idea of a once-a-year implantable. Go ahead and vote. This is the focus group kind of thing. See what Beatles song we have next. So we're still in the 1964 era for Dr. Duak, probably before he was born. Okay, let's see. All right, most people stuck with, sort of, there's those rapid adopters who sort of are going to jump off the cliff without looking, and then there's the cautious ones who go, how'd they do? Yeah, so I think I'm not going to spend a lot of time with discussion here, but just I'll let Jeff comment, but the implantable is attractive, right? Because with a shot, you're not going to throw away your shot, but you can certainly put it in and hang around for a while, and you can't exactly dig in there and extract it. But a implantable means if you start having an adverse effect, you can take it out. Jeff?
I'd like to follow up on what Carlos said about failure or a public health emergency. And obviously it varies in certain areas of the US, but a significant proportion of the transmission is coming from people who know they're infected, but who have factors that impair their ability to take daily therapy for 50 years, right? And so if we really want to cut down on transmission, obviously we need PrEP and PrEP resources, but we also need better, longer acting therapy, in my opinion, that 10 to 20% of people really need in order to remain suppressed. So I would have voted, if I'd voted, for the implantable, because that's something that we've shown implantable works very well for other conditions, such as pregnancy prevention and certain psychiatric conditions and certain types of patients. So I really think that we need better, longer acting therapy.
Yeah.
That's my
I
opinion.
think that's where the development's going, and even though there might be issues with BNAB development, there could be a role for that. But I just wanted to stimulate thought and incorporate what we'd heard earlier.
So I wasn't here when Jeff presented, but I came out of Croy a little disappointed with BNABs.
Yeah.
And a little more excited about
We saw the data, and Danny shares your concern. He's now running with molecular scissors and is going to be doing CRISPR-Cas9 and rejecting the beetles. It's very disappointing to me. Okay, but other people felt the same way, Carlos. So we have a woman who's 30, newly diagnosed, got appropriate HIV screening, and she's 6 weeks pregnant. She's got the same profile, except we include a B5701, I'm sorry. And
I'm sorry, what was that test done?
Huh?
Why was that test done?
Well, because it was a carryover on a sheet that had an order set that just came through.
Because I see no reason to order a test like that anymore.
Well, it's it's like an archaeological dig, and so it just exists. First pregnancy, okay to start therapy. What would you use? Go ahead and vote. Good day, sunshine. Okay, let's see what we got. Oh, I'd do that. Sorry. Okay.
Good.
Let's hold that thought. I'll just comment. Let's come back to that with the next question on the bictegravir. What I think has emerged as a preferred regimen that was out of step and was almost malpractice 4 years ago is the dolutegravir TAF FTC, because there's been large studies now that show that it was superior to efavirenz and to other things. The TDF could be in there as well with the dolutegravir FTC, although TAF was viewed a little bit more favorably, and it led to this kind of look in the guidelines. So you'll see again the TAF and FTC is preferred, and the dolutegravir in bold. But abacavir is acceptable. We don't use it much anymore, and that's kind of where we are. But of note, back when this was published, bictegravir, that the majority of you picked, had a data set that was growing but wasn't quite to where it needed to be recommended. So now let's go to this next case, this is a woman who is 6 weeks pregnant. She was the one that we just treated in the first case, right? 85 or 82% said I'd give her Bic-Taf FTC, and she's still on it and doing quite well. Her CD4 count has skyrocketed, and her viral loads target not detected, and this is her first pregnancy. Now the question is, and you'll see why I didn't comment first on the original case with a woman who's pregnant. She's on TAF FTC and bictegravir. Do you continue that or change to one of these options below? And I've just, laid on my sword for the data for option D, what would you do? Go ahead and vote. Okay, let's see where we are. Now we can have a conversation. Melanie, it looks like you're leaning forward to answer. Let's see what you have to say.
Well, I would just back up and say that in terms of initial therapy, there has been a change in the perinatal guidelines, and so Big TAF FTC is now an alternative for pregnancy. So I think that is a good choice for people. And also, for a while now, we've said if people are doing well on their current therapy, including Bictegravir, TAF, FTC, that they can continue on it. You know, the reason it was made an alternate therapy was really just that there's less data than has been accumulated with dolutegravir and so on. And so, you know, but I think it's a very good choice. And what I wouldn't do is to use rilpivirine because we really don't have data for these two drug regimens in pregnancy. So I would not do that.
And I would add, I think when you go to what's not recommended, to Melanie said, remember, no cobicistat in pregnancy. And the data that you mentioned, again, no reason to use efavirenz anymore, really. It's actually worse outcomes. So there's regimens there that you shouldn't use.
Yeah, I think the cabotegravir is certainly not a good option at this point, even though for some people in harm reduction, it might be the only way they can get treatment, but that's an exception. And I think so far the dolutegravir 3TC alone, which isn't really on here, is probably not a great option. But I think what's changed, and that was the point of the question, is that bictegravir is now generating enough data. And it had some PK reduction that raised some potential concern, but the clinical data are supporting its use, and it's working pretty well. Let's move on just to get, this is where I want to spend some time. This is one of the pre-test questions. Should I recommend breastfeeding postpartum? So this is same woman. Now we've advanced, and she got on dolutegravir, TAF, FTC. Her viral load quickly became target not detected and remained so throughout pregnancy. She's obviously very adherent to the regimen. Healthy baby girl delivered 2 days ago, and she says, I'd like to breastfeed. And what do you tell her? Yes, she should feel fine to do it. Nope, not safe. Or discuss the pros and cons, and so have a middle of the road thought. Let's go ahead and see what you guys think. So we're still in the early era of Beatles music. It's a Paul McCartney song. Yeah, I know. Sorry, Danny. It is fascinating, though, to watch them creatively. Their creative output was remarkable, unlike some researchers that I know. Okay, let's see. Sandy, do you have an opinion here?
Sorry. Yeah, I agree with C, and it could be A too. I think that there's data to support. I think definitely having a conversation always with the patient is a good thing to do.
Experienced test takers in the audience.
No brainer. But there is data to support it. She's virally suppressed right now, and data to support that she could safely breastfeed her infant, and very different than what we used to recommend. Yeah.
Other thoughts, panel?
I think, the guidelines were changed last year. The recommendation is exactly that. And it's funny how it's worded. It says the risk is, you should tell the woman or the person the risk is not 0, but it's exceedingly low, is less than 1%. Well, I don't know anything that has a 0 risk in life, right? I mean, I drove here, I crossed the street, I'm going down the stairs. I mean, we all take risks, but the risk is really, really small, and the benefit of breastfeeding is very high. So I think we need to be able to message that correctly, right?
Yeah. So a little bit of history here. initially it was viewed as not a good idea. And then in sub-Saharan Africa in particular, as well as other parts of the world, it was hard to gain access to formula. If you even had the formula to get drinking water that was reliably not contaminated. And breast milk was a way not only of getting good nutrition to babies, which sometimes were at threat of malnutrition, but it also helped prevent the mom from outing herself. Since so few women actually used formula, they said, what's wrong with her? You know, why is she not breastfeeding? And so it was pushed. And then the whole concept of U equals U came along. And why wouldn't it be safe if the viral load is sustained as undetectable? There should not be transmission through breast milk. And the risk over time of transmission in the absence of therapy is about 6%, 9%, depends on the study. So it's substantial, but when you give the U equal U approach, you'd think that it would be great. So they liberalized this, had focus groups in South Africa in particular, and the vast majority of women said, I want to be able to breastfeed, and they said, go ahead. They went ahead and studied it, and there, for the overwhelming majority, there was no transmission. However, unlike U equals U, where it's hard to find a case of transmission sexually that happened without an extracurricular partner being involved, where they do genetic analyses, they did find a rare transmission in the setting of documented suppression. Now, was that an error of someone not taking it for a period of time and just got missed? I don't know. But that's where the guidance, as Carlos just said, changed to say generally safe. However, you need, before you go forward, just explain that there's 1 out of 730 women in sub-Saharan Africa who had the study. The data in the guidance is really very clear about what the data are, and it's really played out. So if you want to do the counseling, you just go to the guidelines. It'll give you the background information you need, and it's probably good to have a conversation. On your pretest, I have to apologize. The original question was just yes, no, and most of you kind of got it for yes, and I agree with that mostly, but I think in the revised, you'll see this answer. So at this point, I'm expecting 100% accurate answers here, so I'm coaching, and we won't have a 99% failure rate. But it's really fascinating. I can't explain biologically why there would be transmission through breast milk in a woman who's truly target not detected and that's sustained. It doesn't add up to me. Okay, now we're going to get into some heavy topics, and we're going to lean a lot on Dr. Grinspoon for this. 47-year-old woman started BICTAF FTC 12 months ago, as 82% of you would have recommended. Viral load wasn't even that high, wild-type virus, pretty early in disease. Maybe we could argue should have been prevented from public health perspective, but does well. Viral load plummets, CD4 count rises, as well as her weight from 145 to 171. And this is very bothersome to her, as I think it is to most of us in that setting. Her hemoglobin A1C is 5.9, fasting glucose 101. So, in addition to diet and exercise, which everyone rolls their eyes when you recommend, it's kind of like, what do you think I've been doing? You know, this isn't necessarily a choice here. Would you do no other intervention, get rid of the TAF, get rid of the integrase, start metformin, start semaglutide, which could also be pronounced semaglutide, and ramp it up to 1 milligram sub-Q a week, or some other option? Vote. All right, so we now moved up to 66, 67. This was Paul McCartney's attempt to have a theme album that kind of failed. It didn't really hold together. It took Tommy and the Who to really do a rock opera. The Beatles didn't quite make it. All right.
Oh, boy.
Dr. Grinspoon, give us a tutorial on semaglutide, which you call semaglutide.
Okay, there's a lot to unpack here, but first of all, I mean, I know people don't like to change ARV regimens for resistance, but it's pretty clear what is happening here. So I just throw that back out to you. So, you know, if people feel that the net benefit of staying on that drug is, you know, better, more advantageous given the weight gain, then so be it. But that is the problem. So it can be dealt with in a couple of different ways. First of all, right now she weighed 179.
71.
171.
Let's say her BMI is now 32.
Okay, so she's in the obesity category. Whether she has specific risk factors, she's pre-diabetic for sure, so that's a problem. I don't know what her blood pressure or whatever it was. And pre-diabetes is a risk factor for cardiovascular disease and for future development of diabetes. So she's on a bad path, even though her numbers are pretty normal right now. If you didn't know this whole story, a dime a dozen, you know, glucose of 101, most doctors don't do anything, but actually that is a risk factor for cardiovascular disease. So semaglutide is a GLP-1 agonist, and it is very, very effective for weight loss. It primarily acts by decreasing appetite and also delaying gastric emptying. You feel full, you don't want to eat, you're not hungry. It has an amazing efficacy rate and can reduce weight 20-25%. The newer double and triple ones can even go, tirzepatide can go even higher. Its long-term safety has not been determined because the studies are not that long, but there are some possible effects of pancreas, also medullary thyroid cancer, but these are very, very rare things, and so most people view them to be very safe. They are associated with muscle loss, and so we should talk about that in a minute. You know, her BMI is 32. I think it's justified that you could start semaglutide. You'll probably, unless you switch your ART, you'll never get her off semaglutide ever. The weight will come right back. And this is the sort of the trap of semaglutide, is that there's no real off-ramp for semaglutide. You could try to do weight and exercise, and it never works. So not to be depressing about it, but it's just very hard to get off semaglutide. And I know many, many, many people, independent of HIV, who ask me, "Oh, I'm just a little bit overweight. Should I go on semaglutide?" And I say, no, you should not do that. But so many people are going on. It's become a Hollywood drug, unfortunately, and you won't come off. But for this particular case, because she has pre-diabetes and it seems to be rapidly gaining weight, if my ID colleagues told me it was not possible to switch her regimen, then this is a reasonable option. You could start with metformin. Let's talk about metformin. It's an insulin sensitizer. It causes modest weight loss, extremely modest. It's nothing like semaglutide, but it's a little bit. It kind of makes you have gastric upset, and that may actually lead to some of the weight loss, but that tends to go away over time, and then people tolerate it, but it is still associated. It's an excellent insulin sensitizer. It's a relatively safe drug. It's been used forever. It's much less effective than semaglutide.
Yeah.
And she doesn't have severe glucose, although you could argue that she's on the spectrum of going to diabetes.
Right. I'll just make a few comments to finish us up here. So, number one, it does work. There was what I called semaglutide Row at Croy, from abstract number 790 to 798 or something, and it weight loss, cardiovascular benefit, reduction in inflammation, liver fat reduction, improvement in cognitive thinking, help with addiction urges, and I kind of like, if you listen to Frank Zappa growing up, there's a song called Cosmic Debris where he says, and it'll cure your asthma too. That's what it kind of felt like. and I couldn't find hardly any negative there. I'm sure there will be as it gets used more, but it really does work. The other comment I want to make is about changing regimens. There's definitely an association of more weight gain with TAF versus TDF, and that's probably more due to TDF being causing some lack of weight gain because of interference with appetite in some kind of way, but that's not a reason necessarily to choose TDF over.
The steatosis is very important. It is very effective in that regard, and the SELECT trial showed that it reduced heart disease in non-HIV patients by 20%.
Yeah.
I'll contrast that with what we found in REPRIEVE later, but it's a different point. So there's a lot of positives. I mean, I think the world, endocrinologists and metabolism people are like,
Yeah.
Is there going to be any negative on this? You know, I don't know. And this is a first-generation drug. Pharmaceutical companies will develop second, third, fourth generation, and they're just recapitulating the body's wiring
Right.
to suppress appetite.
Probably about the time this gets generic and cheap, it'll have to be
Yeah,
used in
that's
something
it.
else. But the point is that switching off of TAF and NSTs does not lead to weight loss. So it's a fool's errand, unfortunately. Metformin, I'm glad you addressed. I think that's something that the insurance companies often require you to have tried before they will approve. That'll all change, I think, in the next 2 to 3 years. But Melanie, you're going to say something?
Well, I wanted to ask Steve.
To the microphone, please. Yeah.
Since you have the opportunity to pick your brain, something that is happening is that people are going online and they're getting compounded semaglutide
Yeah.
for a couple $100 a month. What do you know about compounded semaglutide? I'm sure it depends on who's doing the compounding, but you know, this is of some concern because we don't really know what people are getting.
That is very concerning. I mean, I don't even know what strength or dose or whatever, how it compares to pharmaceutical grade semaglutide. You know, if there was a debacle with compounding pharmacy and the fungal thing early, I mean, so you always have to worry about sanitary conditions and whatnot. So yeah, I would never endorse that for my patients. I mean, it's possible you could find a very good compounding place that you trust. It's not always bad, but you know, generically, I would be against that.
People always rail against the government, right? That's a favorite thing for folks to do. But a lot of those government regulatory agencies are really do a good job of protecting us. Like the FDA makes sure that a drug is the drug and that it's manufactured under good manufacturing processes. The FAA, we're going to some of us hop on airplanes today. We don't worry about planes running into each other in the sky because they do a good job. And so let's give a tip of the hat for keeping our drugs clean in our airplanes, away from near misses, which is also a misnomer. It's a near hit. A near miss would be a hit, just saying. So what do I do with a patient who has a discordant CD4 response? So this is a woman who started on a darunavir-based regimen 4 years ago, 78,000 CD4 count, 80. But years later, she's suppressed, but the CD4 count only went up about twofold, and she's tolerating the regimen well. So what would you do? Continue the regimen, change them around in some kind of way, add fostemsavir to her regimen, add IL-2, remember that? Let's go ahead and vote.
I'd give her soluble CD4.
Now this song is not so good. Yeah, that was Ringo. Yeah. Okay, let's see what we got. Bang, bang. Continue her current regimen. Some folks would change around. Sandy, you have a thought on this? What do you?
Yeah, I agree with the A. You know, it's funny when you were saying that. This used to be, I remember when I was a fellow, this discussion, but I remember carefully, and it was nice to see that you talked about Steve Deeks, because I remember going to, I think it was a Croy, whatever it was back then, and you know, just continuing individuals on their antiretroviral therapy carefully. The NRTIs were the ones critical. But anyways, yeah, no, it would, and also I remember the IL-2 studies that were going on. And one, it was in administering, and it didn't do too much. But yeah, no, I think the good news is the person's virally suppressed. That's the goal. And we know that individuals, if they can maintain their viral suppression, even with a lower CD4 count, we are not seeing the opportunistic infections, et cetera.
Any of y'all have experience or knowledge about fostemsavir?
Well,
Yeah.
go ahead.
Yeah,
I mean,
go ahead. You're on a roll.
I think, the concern, there is some marketing suggesting that potentially it doesn't have it could potentially increase your CD4 count, but I don't think the data is really there.
Right.
And so that's the concern that I have, and I know you've voiced this as well, is that be careful for switching to this other agent unless just for that particular purpose, because I don't think there's really data to support that.
So I put it in here for a reason, and that is that at a conference I was at about 5 months ago, there was like a side sort of session just to delve into antiretroviral therapy issues, and several people, at least 2 or 3 out of the group of 30, said, well, I would add fostemsavir. And I said, well, where did you come up with that? And they said, well, I heard about it, and it's being recommended. The details are that there are some hypothetical means by which that drug might increase CD4s, but there are no clinical data yet. And you're adding a drug, we aren't substituting, you would add this to the regimen to the tune of about $100,000 a year cost, and there aren't data yet. So I put it in here just to alert folks that I think it's premature, number one. Number two, when you look at the biology, this is something I showed at this meeting frequently, but just to recap, this is what you want to see. You start antiretroviral therapy, viral load drops pretty quickly, and CD4 count gets most of its bump in the first 6 weeks. And that's likely because of release of trapped cells in lymphoid tissue where there's inflammation and adhesion molecules like ICAM and VCAM, and those go markedly down as the viral load drops because the inflammation induced by that viral replication goes away and the cells get re-released. Think about it like demargination with steroids and neutrophils when you give that. There are some people, however, who, despite the viral load going down, don't get that 6-week bump. And if you look carefully, over time, out 3 years, the slope of the increase is about the same. So what it's saying is that magic, if you will, in the first 6 weeks just isn't attained. So we can't go back and make their lymphoid tissues different, which is probably the fundamental difference. And Dr. Duack has done many studies looking at lymphoid aggregates in gut and other places, and you can tell in some people with advanced HIV that that's kind of destroyed, and there's just not a reservoir, if you will, of CD4 cells to be re-released. At least that's my read on this. The second thing is that with the IL-2 studies, for those of us who went through that in the mid-90s, the IL-2 does increase CD4 count quite substantially to the cost of some shake and bake. When you give it to people, it creates side effects, but the CD4 count goes up. But there wasn't much protection against OIs compared to those who didn't get IL-2. And I think the reason for that is not, we don't say this enough. The immunosuppression of AIDS, the reason people get OIs, has very little to do, if anything, with CD4 count. It has to do with a virus. When you suppress the virus, the immune system functions again. The virus is the evil empire. You know, that's the Darth Vader. It's the problem. And when you suppress the virus, the immune system wakes up. And how do you know that? Iris, right? Iris happens because you've driven the viral load down dramatically, and all of a sudden the immune system kind of wakes up like Rumpelstiltskin and goes, WTF? Where did that come from? And it starts to attack. Somebody who's been on therapy for 4 years like this person, and their viral load's been suppressed, regardless of their CD4 count. How many of you seen a patient like this develop CMV or MAC or pneumocystis for that matter? You don't. So that you don't have to obsess over the CD4 count too much. We could go in a little further, but I think that
And that's a very difficult message to talk about with your patients.
yeah,
Because everybody tells them they should focus on their CD4.
that's right.
So it requires reinforcing multiple times. And if somebody proved to you that, fostemsavir increased your T cell count by 50 cells, it would be irrelevant, right? Is
Yeah.
your whole point.
I think so. And I will say this, that there are some cohort data, to give you the full picture, that it shows that people who don't get that bump in CD4, in terms of long-term mortality, do not do as well.
But not from OIs.
Exactly. So the point is that that's probably an epiphenomenon, a marker that someone who doesn't have that boost because maybe their lymphoid tissue has been destroyed by the infection leading up to the point of treatment, that's kind of, there are other things that are damaged perhaps that we can't measure, and it's a sign, but you can't fix that with IL-2 or just bumping artificially the CD4 count up.
So,
go
I
ahead,
was going to say, and again, I agree with Jeff, it's a hard message, but the most important thing here is stop measuring CD4 counts, because, it doesn't help you. And in fact, in the Global AIDS program through PEPFAR has stopped doing routine CD4 count monitoring and saving a lot of money by doing that.
Yeah.
And on a flat budget, still be able to increase the number of people on antiretroviral therapy, because again, it's a test that costs money and is not giving you any information.
Right. And the
Again, we
IAS-USA,
need to advocate for removing CD4 counts as a monitor of care quality.
Yeah, correct.
right.
Just get rid of it. If you're on treatment and your bile load's suppressed, why are we wasting money on
And for the last two iterations, you're on the panel, and Melanie, of the IAS-USA guidelines, Sandy's on it, it's been recommended not to follow once the viral load. I think it's a good recommendation. So this is going to be something that doesn't happen all that often, but it's going to be happening a bit. So we got a 34-year-old who was receiving CAB on Dr. Del Rio's recommendation for his PrEP, and he presents with what looks like an acute retroviral syndrome. It would be rare, but let's, for argument's sake, say this happened. And the tests are unambiguous. The positive antigen antibody test, which may not be positive, and of HIV RNA, which may not be 10,000, but a lot less. I'm not going to go into all that, but it's hard sometimes to see when there's been an infection, but I'm making it straightforward. And a resistance test genotype is sent. And while you're waiting for that, what regimen would you put this person on? They're on CAB alone as their PrEP. What regimen would you use to start? Go ahead and vote. I know, it's not too good either. Okay. All right. And if you want some fun, take Obla-di-blah-da. Okay, Melanie, you got an opinion here?
My opinion is that this group loves BF-TAB. So, but there are reasons not to use that in this circumstance, and I think in the PrEP trials we've seen that you could be dealing with a person who has cabotegravir resistance, and the guidelines recommend, in this particular instance, starting a boosted PI regimen, particularly boosted darunavir plus a tenofovir 3TC or FTC regimen. So I think it's
Well
just,
stated.
And you'll get that INSTI genotype back, and you might be able then to change to your favorite drug.
Right. So that's the point of this. You'll notice that I designed the question in a way that there's really only one correct answer this time, and it was C. So 2/3 didn't make it through, but maybe on a post-test we will. I don't remember this as a pre-test. But anyway, that was the point. That was the point. There only have been a few breakthroughs of CAB, which is flipping around. It's remarkably effective, right? So if people get it every 2 months like they're supposed to, they should be protected. But if there is a breakthrough, it's probable that there's going to be cabotegravir resistance, at least until proven otherwise. So when you go to cover them, don't use an integrase inhibitor until you know more. That's the take-home point.
And can I just put a plug in for not waiting for that INSTI test result to come back?
Yeah.
Go ahead and treat.
Yeah.
You know, there's no reason to be delaying. The person is in front of you, and there is an opportunity there, and we all know how many people have difficulty coming back once they leave the clinic.
Great point. So this is a common issue that I think every one of us sees. We got a guy who's using on and off different substances outside the clinic, comes to see you and happens to be off of their therapy at that moment. They had prior exposure to all these different regimens that you see, and on occasion has had documented viral load that's suppressed, but then falls off the wagon a little bit and it comes back. When you carefully question him, he's had no toxicity or significant AEs. He just, at times, just doesn't want to take a pill or two. And he just has demonstrated over the years that that's just not something, despite whatever coddling you do or encouragement, just doesn't work out. And his only resistance documented is M184V. So, what would you do in this setting? His viral load is 200,000. What was, let me go back, I'm sorry. Yeah, 200,000, and CD4 count is low, and this is your situation. What are you going to do? Here are your options. Go ahead and vote. Ooh. Interesting song. Helter Skelter. It's off the White Album. Yeah. It stimulated Charles Manson to murder people. So if you're crazy, this is a bad song. Don't listen to it. Okay. Whoa, all right, 2/3. Amazing. Who wants to take this one? Carlos.
I agree with the 2/3. I think this is ideally where, it's interesting. This drug was not approved. The current approval of this drug is for people who are virally suppressed and doing well. The place where we need this drug the most is in people who are not virally suppressed and not doing well. So increasingly, as was mentioned by Sandy and others, there's data saying this is a good population, and I think the ACTG study presented at CROI very clearly showed that this is a good option and something we should do. And again, you can probably go directly to the injectable and not go the oral induction and then go to the injectable. The two concerns that I have here, well, two things I would add is there was a history of rilpivirine use at some point in time, and I worry whether there's going to be 103K archival mutation somewhere, and I'm just a little worried about that, but I guess we'll have to take the plunge and see what happens. And then, with the history of and I would like to turn this over to ask Sandy, with the history of meth use, maybe it's a combination of cabotegravir, rilpivirine, and Ozempic, right? So to deal with the cravings of his meth use, because if he's going to be coming to clinic, might as well just use all the tools we have.
Naltrexone?
Yeah.
Ozempic. Yeah,
So
no.
is this in your harm reduction vending machine toolbox?
Well, if you had been listening. No, the idea is that it could be his ongoing methamphetamine use, definitely interfering with his ability to adhere and stay and come to treatment, get refills. We don't know the whole thing. It could be other associated factors, but definitely recognizing that as there's a lot of clinics that don't have contingency management, but and I didn't get to go into this, although there's no FDA-approved medication treatments for methamphetamine use. There is also, evidence for naltrexone, extended-release naltrexone with bupropion. It depends on the patient, but there's things, and you don't know other substance use if he's using alcohol and other things. But the other point is what, I just want to emphasize what Carlos just said is really talking to the patient and what were the issues. Is it really adherence? There is a concern for resistance, definitely, and I was concerned about the rilpivirine as well because I have seen that. But what is it that we could do to help help him stay on medication?
Yeah.
And could it be a long-acting form of treatment and other? Is it beyond that, do we have to bring the medication to him? Do we have to help with support systems in addition to his ongoing substance use and other things? So things that we have to think about that
Right.
are not traditional.
So this, where I'm required as part of CME to tell you when we go off label, we are off label, okay? Because the label says get the viral load down. Now, Carlos referenced the ACTG study. Interestingly, that study required patients to go undetectable. Initially, I think it was for 4 months or something, and then they'd reduced it to 2 months. And even that was hard with incentive. They were paying people to have undetectable virus, and I think only 60% achieved that. And then they would go get cabotegravir or not, and it worked. This recommendation that was an update in JAMA just before CROI by the IAS-USA guidelines panel said clearly, if someone's unable to take oral ART consistently despite efforts, and there's a high risk of HIV disease progression, so that's this guy that we just saw, and virus is susceptible to both CAB and rilpivirine. So by the testing that was done, that's true. Carlos mentioned archive virus, possible. More and more data, in my view, is showing that the archive virus population doesn't matter that much. So getting a DNA test to see if you see a resistant phenotype or genotype, it doesn't mean the regimen's going to fail necessarily, but it is a concern. I agree with Carlos. But this is a clear harm reduction thing because this guy's not going to make it. And we've already given him extraordinary, I think, effort. And we see these, everyone's seen a patient like this? Yeah. I mean, common. Every head's going, yeah. And it's problematic. But I think the purpose of getting this out before the updated guidelines come out, hopefully in December of this year, was because people were recognizing from data that Monica Gandhi and others sort of went out there on a limb and did some studies of this, not large numbers, but enough to say this feels like the right choice under those circumstances. Okay.
Mike, could I just add something to that?
Sure.
That I do think there is some concern about rilpivirine resistance, and you might see it in all that circulating virus that the person has. You might not even have to go to an archive. But there was an interesting poster at CROI, again by Monica, who looked at lenacapavir plus cabotegravir. Now that's off-label.
Was this oral or
Injectable. Injectable lenacapavir plus cabotegravir. Obviously, lenacapavir is every 6 months. Cabotegravir is 1 to 2 months, so they don't line up. We don't have a great companion for lenacapavir yet. But nonetheless, in this very advanced, at-risk group of people, there was some success. And I think Monica and others have been pushing for a clinical trial, and I understand now that is beginning to be put together in the ACTG.
Right.
So I think there are some additional options out there
Yeah. And
for
I think,
a desperate situation.
and what Jeff said earlier, that the field is moving towards longer acting, and we'll see this over time. So this is a question about STI prevention. 35-year-old male, 10 years ago with HIV, success with antiretroviral therapy, but he's coming to our clinic about every 6 to 12 weeks with an STI. Anybody see anybody like this? Okay. And it can be any one of a myriad of STIs. And so now, what are you going to recommend? Counseling and scolding, offering amoxicillin, doxycycline, or cefixime? Go ahead and vote. This is a good song. All right, let's see what we got.
Here comes the doxy.
Yeah. Here comes the doxycycline.
95%, very
I had to hold back. All right, so we don't need to talk about this very much. And I was going to have Kim
I think we do.
comment.
I think we do in the sense that, again, this is going to be helpful, very helpful against syphilis and against chlamydia. It's not going to be helpful against gonorrhea.
Not quite as much.
And I think we need to be very clear about that because this person is still going to be at risk of gonorrhea, especially because, the data, I mean, if you're talking here in Atlanta, about 50 to 60% of gonococcal isolates are resistant to tetracycline, so it's not going to work there.
Yeah.
And therefore, it's sort of a two-thirds, solution.
Yeah.
So I think we also need to realize, this works very well for a lot of people, but you still need to do the testing. They still need screening.
Yeah,
So you can't just say, oh, doxypap, great, bye.
See you later.
Yeah,
Yeah.
see you later, come back, for your annual wellness exam. So
Right.
that's not the way it works, and I think it's really increasingly important to do that regular screening for these folks, because they are certainly
Absolutely.
continuing to be at risk.
Yep. So this is a case I saw about 6 weeks ago in clinic. This is a guy who showed up with new lesions on his buttocks, groin, back, and face. He has sex with men, reports fever, although he's afebrile in the clinic, denies sexual activity over the last 12 weeks. HIV RNA is a little bit out of control. He's not on antiretroviral therapy. His UDS is positive for meth. Give you a couple of more pictures here. Those lesions were scattered on his body. And he also was sort of sitting on the exam table, just curled up and just miserable, and the sheet over his head kind of thing. So you're going to treat for molluscum, start tocilizumab, TPOXX. Are you going to wait for cultures if positive? For mpox, then start TPOXX. Would not treat, no specific therapy, or just give him benzene penicillin. Let's go ahead and vote.
I'll start by saying that it's easier to get tocilizumab than benzene penicillin. Cheaper.
That's cheaper.
Okay, that's a warm-up song that they had. All right, so most people went with TPOXX. About 16% went for syphilis treatment. What say the panel?
I think the fact that it was so exquisitely painful would argue against syphilis.
Uh-huh.
And so obviously we've all experienced how painful, hopefully not personally, but maybe in some cases,
Yeah.
how painful mpox is.
Right.
So I would think that, it's much more likely to be mpox.
I mean, the ironic thing is that we were talking with Melanie here, it's easier and cheaper to get tocilizumab than benzene penicillin anyway.
Yeah. So this is where I got fooled by the great masquerader. I was thinking exactly the same, gave you TPOXX, filled out all the forms. God, I hate that, but you got to do it. And did check for other STIs, and his TPOXX PCR came back negative, and his RPR was through the roof. And the people that do a lot of STI, say, oh yeah, that looks like syphilis. And I'm thinking, it looked like mpox to me. So it's hard to tell, but always keep the great masquerader in mind. On the right here is a similar patient I saw about 2 years ago, whenever the outbreak was. And the lesions do look, that's more of a Lottom type lesion on the left. But anyway, just kind of, we can all be fooled. And I should be playing the Who like we won't be fooled again, but so much for that. Now, we're finishing up with the question that came from the audience earlier today. So here we go. What do we do with an isolated hepatitis B core antibody? I promise we get to it. So this is the last case. 48-year-old guy presents newly diagnosed 4 months ago, started on dolutegravir TAF FTC. I use the same viral load. Other labs were normal. Genotype was wild type. Hepatitis B surface antigen negative, surface antibody negative, hepatitis core antibody positive. HBV DNA is detectable, but less than 1,000. Now doing well, and he wants to simplify the regimen. He's got a viral load that's suppressed. He wants to go on cabotegravir, rilpivirine. What do you do? Go ahead and vote. We're just torturing you, aren't we, Dan? Can't stand it. Okay, let's see what we got. All right. Most of you are going George Herbert Walker Bush, not going to debt. Change wouldn't be prudent. Not, yep. And 18%. So, you want to take this on, Sandy?
Yeah, so he has a detectable hepatitis B DNA.
Yeah.
So you don't want to be taking off
I'm going to speak up a little bit.
Yeah, you don't want to be taking off the DNA was positive, so he has hepatitis B. So yeah, you can't switch right now.
That's generally the rule of thumb. Any other comments or?
And then I would give.
Yeah. Okay, so the rule of thumb is that hepatitis B, under any circumstance when there's true infection, which this is the case, although it's really unusual, right, can wax and wane. And you can go from antigen negative, surface antigen negative to surface antigen positive over time. That's kind of the way it works. Admittedly, there are not that many data in this precise situation, and so there's differing opinions about what to do. Some liver experts I've talked to about this say, it's not going to work, don't worry about it. Even if they convert to antigen positivity, you can deal with that. It's unlikely they're going to go into fulminant hepatic failure. Others say, no, it could happen theoretically, so don't mess with it. And so it's right on the cutting edge of the gray zone, or as Rod Serling would say, the twilight zone, because there really aren't a lot of data. But I think most folks would say, unless there's an extremely strong reason to get off of a tenofovir protection type regimen, don't do it. Now, this is in the setting of detectable DNA. If you don't have detectable DNA, then you're probably much safer to do it. But in the face of detectable DNA, which usually doesn't go above 1,000 in this setting, then a lot of the liver experts say, hold off. But your question was spot on. Yeah, come to the microphone if you want.
DNA.
Yeah. Yes.
Yes.
Yeah, I think I would.
Yep. I would.
And maybe use the Hepaslav just because. And you could probably get by with 2 doses. Melanie will be talking about 2 versus 3. What would you do, Melanie? You're the
Well,
yeah, hit me with your best shot.
It's good, I can skip a slide later on. And you'll be ready for me to skip a slide when we get to the end of the day. So, so the guidelines are to vaccinate with 1 dose and then check. If the person has never been vaccinated, you're going to vaccinate them with a full series. But if they have a positive core antibody and everything else is negative, you're going to give them 1 dose of any hepatitis B vaccine, and then you're going to measure surface antibody titers. And here's what's different. The titer should be greater than 100 for seroprotective response, not 10. Not 10. So that's a little tricky. There might be a question about that somewhere.
Yeah.
But it's 100 for a seroprotective response after with a core antibody. So.
That's great. That's very helpful. So thank you for bringing that up, and it fit right in. I think we're at the end of our time. If there's any other questions, come to the microphone. Oh, we have some. Okay, let's see. We'll just throw these out real fast. Any possibility of getting cabrolpivirine approved for non-suppressed patients? Probably not without a clinical trial, but it will be an off-label in use. Yes, please.
So I have a patient who was diagnosed 2 years ago. He has been on Biktarvy, Dovato, cabotegravir, Descovy-Tivicay, Descovy-Prescovix, Simtuza, and every time he takes ARV, he says, I have a reaction, I can't take it. And this has been a continual issue. I feel like if I do anything else, I'm going backwards off guidelines. What do I do?
Panel.
Did you say he had been on cabotegravir?
Yes, and he had a reaction immediately and said he can't do it.
Yeah, I mean, when you say a reaction, what do you mean by a reaction?
He's complained of GI issues. I said, give it a month, make sure it goes away. He says he's tried that. He's had skin rashes, which when he comes presents to me, I don't see anything. He says, now the medicine's affecting my blood pressure, and it's just been one thing after another. I talked with Dr. Overton. He said, maybe try him on something to ease his anxiety. That's what it sounds like. And when I presented that, he said, oh, no, I can't do that. Let me talk to my doctor, and I'll have a reaction to that, too. So,
I think it's safe to say there's no easy answer. And I think we feel your pain. But you're going to have to, chart a course just through continuing conversation. I don't know that there's any easy way, but whatever it takes to kind of find a happy ground. Sometimes in these settings, I'll have the patient return frequently as we start therapy, maybe even every other day or certainly once a week to kind of get them through it.
His problem is he works and has to travel a ways to come to us, so he can't come quite so frequently.
Yeah.
I'm almost about to send him to 1917, but I don't want to do that to you guys.
Yeah.
You
Well,
know-
we usually do, I do personal house calls in that setting, and I'm there every night,
There's telehealth.
usually with Twinkies and some other things, but no, you're right, it's a tough situation. I don't think it's going to be solved easily, but any
yeah,
other, Sandy?
Oh, go ahead.
But I think the great thing about this is you have a relationship
Right.
with this person. And even though he doesn't like anything you give him, he keeps coming back to you. And I think that is the most positive part about
Yeah,
all of this, because,
I
you
agree
know,
with that.
he trusts you, maybe doesn't feel that great about the medicine, maybe has some underlying mental health issues, not clear. But to me, you check his CD4 count. It's an instance where I would do that. If he needs prophylaxis, try to get him on some prophylaxis to keep him healthy, but keep him coming back and keep talking, and it might change.
His CD4 count has been fine, and actually when we check viral loads, he's taken it long enough where he's still suppressed, but then he takes himself off the medicine. I think last CD4 count was 650, so we have a while before we have to get to prophylaxis with him.
Good.
Yeah, and I think like, well, I agree with what Melanie was saying, also telehealth, I don't know if you have that, he can't, but I think one of the things is he keeps coming back to you, and instead of maybe just one of the things I do is, and this happened for patients, is it was the idea of taking medications that reminded the person and how they acquired HIV, and that in itself was it was hard to overcome, and then just remind him there's a side effect with every single medication we take, Tylenol, ibuprofen, whatever it is, but are these really side effects of the medications, or is it potentially something else that's going on, and to just have that frank conversation with him, and it might very well be that it's difficult to take a daily medication or injection. You said you started cabotegravir, so other things that are going on, and sometimes that takes a lot longer to deal with than giving a medication.
So that's it. I'm not sure it was helpful, but at least we feel the pain.
It felt good to just talk about it, so thanks.
There you go. You feel better now. Good. Told you this is like group therapy of some sort. A couple quick things real quick. So somebody who's been on rilpivirine and is tired of the shots and wants to go back to an oral regimen, what would you use? Does it matter? It's whatever they want to take, I guess, right?
One you guys like.
And it integrates.
Obla, right?
Yeah, okay, right.
You want,
Okay.
you want,
Question about-
FTC with dolutegravir,
Yeah.
whatever you.
It doesn't matter too much because they've been suppressed and that it just switch over. A woman with having difficulty with her breastfeeding where the nipple gets chapped and maybe bleeding a little, do you halt the breastfeeding till it heals?
Well, it depends on whether a viral load is suppressed.
Or it's viral load suppressed. So probably okay to continue as long as it's tolerated. Yeah, I think that's the U equals U kind of concept. Steve, here's a question. The GLP-1 agonist or the data are new, but people in primary care have been using it for a long time. Endocrinologists have been using it for a long time. Is there any meta-analysis to look at longer-term safety in the population over the decade plus that these drugs have been used?
Well, they were initially used for diabetes, of course, as opposed to weight
Yeah,
loss. And so
right.
they've been proven safe for diabetes for a longer time, but that was a different population than they're currently being used for. So there are not long-term safety data in the obesity realm. I think Carlos mentioned something about Ozempic and cravings that we didn't get back to, but I wanted to pick up on that. These drugs have a whole other investigative life cycle, and
Yeah.
it's all about cravings. And there are many, many studies now percolating through the system about use in alcohol disorder use and for narcotics and for cravings in general and bad behavior and da-da-da. So, I think one of their more interesting future uses will actually be in that realm.
Yeah.
And so, they're not quite ready for prime time in that regard yet, but with more research, they might be.
And I'm still waiting on the asthma study myself. Mark, we're out of time. Real fast.
Rosuvastatin may be what every patient.
Yeah, well, we're going to hear about that in a second.
Combination is not
Real
gonna have much
fast.
heart disease.
Yeah.
We just have an interesting case involving Rukobia and T-cell increase. So I have this patient who presented with PAH, and that was his presenting episode of HIV.
Yeah.
And so we got him undetectable, and we actually changed him to Cabenuva, and was doing fine, except his T-cells never went up. So they kind of stuck around 250, and he started having, and he was on some experimental stuff for PAH, so I couldn't even tell you what that was causing, but he started getting all these, not OIs, but a lot of infections. He would have weird skin infections, or he was having GI stuff, and like it was every 2 to 4 weeks. So I was getting really tired of all these emergency visits. And my Rukobia rep, said, well, the T-cells do kind of go up. So I said, all right, let's give it a try. So I added Rukobia to his Cabenuva, and his T-cells went from about 250 to 450 to 500, and all the infections stopped.
Yeah, so this,
So he actually
I'm
got
not,
benefit from it.
yeah, I don't doubt your story, and I think it's important, but what we need are the long-term studies before we really start saying this is a good option. I think it's fine, but it is about $100,000,
No, and I have other patients.
and it's a
who
twice-a-day med.
Yeah, but I have other patients
Yeah.
who have T-cells that don't go up,
Yeah,
and they're doing fine.
I
But this
don't
guy
mean to
was having
cut you off, but we really, we're long, but thank you. I think, we've been working together a long time here, and I respect your judgment, your opinion, and I think it's good.
One patient who did benefit.
Yeah, okay, there we go. All right, so can you come up afterwards? I think
I just want to say that a lot of these patients have severe underlying anxiety. So
Yes.
in response
Yeah.
to the other person who got up, and we underuse psychiatry and psychiatrists.
Yeah,
Yes,
if you can
that's
find a psychiatrist. Yeah, it's hard. Well, anyway, great panel. I want to commend Dr. Thompson. You notice he's wearing a mask, but that's to protect us because she had a potential COVID exposure, and she's thinking of people around her, which I think we all need to do, so bravo. And we're going to come back after lunch. We'll be back at 1:30, 1:20. Okay. 1:20. Enjoy lunch. Your sandwich or whatever is in your name badge.